Fat transfer, long-term outcomes, volume retention, and patient satisfaction. Welcome back to our series on the history and science of fat grafting for breast enhancement. In the previous episodes, we explored the early use of paraffin and other injectable materials, the era of sponges and breast implants, and how liposuction revolutionized fat harvesting in the 1980s. In this episode, we move into the modern era to understand how fat grafting has matured into a widely accepted technique, what the long-term results really look like, and why patient satisfaction is high. After liposuction made large volume fat transfer possible, surgeons began experimenting with fat transfer to correct contour deformities and enhance the breast. In 1987, the Plastic Surgery Society cautioned against using autologous fat in the breast because of concerns that calcifications might be mistaken for breast cancer on mammograms. So microcalcifications are looked for on mammograms as a screening for breast cancer. For nearly 2 decades, this warning limited the use of fat grafting for the breast. Over time, imaging techniques improved, and long-term studies showed that graft-related calcifications could be distinguished from malignancy. Now, that's very important. As evidence accumulated, the fat transfer did not increase cancer risk. Professional societies then rescinded their bans. By the early 2000s, autologous fat transfer to the breast began to re-enter mainstream practice as both a reconstructive and aesthetic option. One of the first most comprehensive evaluations of breast fat grafting was a review and meta-analysis published in 2018. The authors searched the medical literature and identified almost 90 studies covering more than 5,000 patients who underwent fat grafting to correct contour deformities or augment the breast. Across all the studies, the average follow-up was almost 2 years. The review reported exceptionally high satisfaction rate. So people really enjoyed the response of having a fat transfer. More than 94% of the patients and 95% of the surgeons were pleased with the results. The complication rates were low, and the quality of evidence was variable. So some of the studies were smaller, retrospective studies without control groups, of course. Nevertheless, the analysis reassured surgeons and patients that fat grafting could produce natural feeling results with minimal complications. One of the key questions patients ask is, how much of the transferred fat will survive? I get asked this routinely. And unlike implants, which provide a fixed volume, so the pressure of the device presses out the tissues in front of it, and it can't be compressed to the point where that volume goes away. The volume of the implant will always stay there. Fat grafts can change over time. You can have weight fluctuations. And then we've seen all of this stuff happen with the GLP-1 agonists now, burning both facial fat and body fat in general. Surgeons have a long recognized that the technique matters. Harvest, processing, and placement all affect the survival of the fat. And even with optimal technique, not all transferred cells survive. Historically, reported retention rate, the rates will vary. So you can have very low retention or as high as 80% at a year. The variability has prompted researchers to study factors that influence fat survival in as many rigorous ways as possible. A landmark prospective study published in 2024 and updated in 2025 sought to quantify long-term volume retention after breast fat grafting using MRI. 28 patients, 46 breasts, were examined for surgery and then at multiple times up to 3 years after their procedure. The researchers modeled the rate at which the transferred fat reached a steady state and measured how much of the grafted volume remained. They found that the breast reached a volumetric steady state at about 253 days, or approximately 8 months after surgery. On average, in this study, 46% of the injected fat persisted at steady state. That means that just under half of the initial grafted volume contributes to the long-term augmentation. While this may seem modest, keep in mind that surgeons often overcorrect during the initial procedure to account for the expected resorption. By 3 years, the volume remained remarkably stable, suggesting that once the graft has engrafted and established a blood supply, it is durable. So this has always been, I think, the more complicated issue because uh, if you go back throughout time and you have whether it's an Ivalon sponge, fixed volume, breast implant, fixed volume, fat transfer, volume is transferred, it's not fixed. So there is fluid, fat, all sorts of cellular components transferred. That's a dynamic substance, has to be placed in the space where the fat is, has to heal. So that is, in this study, they're looking at it over 8 months. I always feel like the preparation of the patient and the early treatment of the patient in terms of what are they doing in recovery right after surgery has a bearing on the outcome. So, in addition, weight change, fluctuations, I'm asked routinely what's going to happen, over the duration of someone's life. And obviously, none of us can project what's going to happen. Is somebody going to lose weight? Somebody going to gain weight? And then I tell everybody who wants a fat transfer, under no circumstances do I recommend them using a GLP-1 agonist because that actually is going to very much have an influence on fat retention. One of the most important findings of the prospective MRI study was the impact of post-op weight changes on fat retention. The investigators analyzed how fluctuations in body mass index influence the proportion of the fat that survived. Patients who patients who lost just 1 point on the body mass index scale after surgery retained about 22% of the injected fat. In contrast, those who gained 1 BMI point retained about 57% of the fat graft. So that's basically what we're talking about. So the gaining of or retention of fat is directly correlated with, in this study, BMI, but I'm always thinking of, what is the body composition of the patient? And if you gain 2 points in BMI in that study, you retained approximately 85% of the fat. These results highlight that transferred fat behaves like normal fat tissue. It expands or shrinks with overall body weight. For patients considering fat grafting, this means maintaining a stable weight after surgery is essential to preserve results. Significant weight loss will diminish the graft, while moderate weight gain will enhance it. Surgeons counsel patients to avoid major dieting or weight swings, which we talk about. Plus, now we always have to qualify this conversation and include GLP-1s. So you got to maintain or improve your weight. Basically, in this situation, we want you to put on healthy weight. There's this concern over gaining weight. Like we want obviously maintenance of lean body mass, skeletal muscle, and then healthy body fat. We don't want more visceral fat, of course. We know that's detrimental, but we want to maintain a healthy body weight. In that same MRI study, it also explored how the volume of the fat injected relative to the volume of the recipient site influences the final outcome. So this is always, right patient, right time, right space, right amount. So the researchers observed that higher graft to recipient volume ratios were associated with greater percentage increases in breast size, and there was no plateau even when the ratio approached 2 to 1. This suggests that surgeons can achieve more volume by injecting greater volumes. Of course, there's a practical limit that is imposed by the skin stretch or the skin itself, and obviously the blood supply. Overfilling can lead to pressure-induced necrosis. So I always tell patients the skin dictates what you can do. It's not how much I can put in. Obviously, I can, inject more and more fat graft if, in fact, we have that much to harvest because the patient has that much fat available. I always tell patients when you're doing a fat transfer, I always would consider addition to the fat so that you can add to the result, improve the result, and that's how I think about it. Since the 1980s, surgeons have continually refined fat grafting techniques to maximize cell viability, harvesting fat with low pressure, as popularized by Fournier and then Dr. Coleman, minimizes trauma to the fat. Processing methods such as centrifugation, filtration, and washing all have had their runs, if you will. We now use closed systems. Due to the stance of the FDA on manipulation of the fat, I personally don't add anything to the fat. And beyond objective volume measurements, patient-recorded outcomes are critical. In an MRI study, patients completed the breast Q questionnaire, which assesses satisfaction with the breast appearance, psychosocial well-being, and sexual well-being. Scores improved significantly after fat grafting, reflecting that even when only half of the transferred fat persists, the enhancement is meaningful to the patients. Many appreciate that fat transfer provides a more natural look and feel compared to implants, avoids foreign materials, and eliminates the risk of implant-related complications. The procedure also offers the bonus of contouring donor areas through liposuction. And now patients have to understand to achieve a desired appearance change, it requires more volume, it requires maintaining weight, if not improving weight, like we already discussed. Certainly worldwide, breast implants remain the most common method of augmentation because they do not depend on weight fluctuations. They can be done, obviously, in lower BMI patients. However, implants always carry risk because it is actually a device. You can have a capsular contracture, you can have a rupture, you can have development of rare forms of breast implant-associated cancers. You can have infections because it is a device. Fat grafting avoids implant-related specific risks, obviously, because it's autologous tissue. The choice between implants and fat transfer really depends on individual goals, body habitus. So how much do you have in terms of fat storage? What can I use as a site to remove fat from to then augment the breast? Research into fat grafting continues to evolve. Studies are exploring how to optimize the donor sites, like where is the best fat, processing methods, always enhancing retention. Investigators are examining the role of adipose-derived stem cells all the time, extracellular matrix scaffolds, tissue engineering to create even more stable grafts. Meanwhile, clinical trials are assessing the three-dimensional imaging and computer modeling to predict outcomes and plan procedures with greater precision. We always want to deepen our understanding of how to utilize fat graft to become even more reliable and versatile. In this episode, we've examined how fat grafting emerged from the shadows of being not in alignment, concerns over cancer surveillance, and those have been vetted now. We do know how much we expect fat to really be retained between we'll say the 46% and the 85%, depending on fluctuations in weight. Ongoing advances in technique and technology continue to improve outcomes. In our next episode, we'll explore contemporary controversies and innovations in fat grafting.